Well, welcome everybody. I'm Bill Sappenfield. I'm actually a pediatrician epidemiologist by training and a professor at the USF College of Public Health. And my biggest pleasure is being the director of the Florida Perinatal Quality Collaborative. For those who don't know about us, we're now celebrating our 11th year. We are a statewide partnership working with hospitals and providers to improve the quality of healthcare for all moms and babies. And we really do that in partnership with everyone. We're voluntary, we're evidence-based, we're data-driven, we're population-based, and the whole idea is to be value-added for the family, value-added for the hospital, value-added for the community. And we're really pleased to have this opportunity to talk to you about one of our initiatives. I know some of you have not necessarily been part of one of our FPQC initiatives, but we use an IHI model to try and do that. This is really to be an interactive discussion. We chose Zoom. Please feel free to stop us at any point and ask questions. We'd be happy to talk you through that. This is actually unusual. COVID, we've given the opportunity with the Department of Health to extend the initiative for a whole extra year, because many of our hospitals have not been able to create change during COVID, and they wanted more time to work on this important issue. The other new thing is we're going to actually open up for new hospitals. And the reason we're doing that is we actually have a model change package that helps hospitals to really enable them to readily change the quality of care they're provided. And in fact, the work here in Florida is becoming a national model for many other states. And so we wanted to give the opportunity for others to join in, especially since we're currently covering a little less than half of all the NES babies born in the state. I say NAS because the problem is even larger with the mothers, but our data in Florida on the mother side is not very accurate. So we only know the counts on the baby side, but we know that there are more mothers than babies. Anywhere from 20 to 40% more. So what we're going to do is walk through some of our package, and our hope is to answer questions about what it takes to be involved. And we look forward to having a discussion. Let me introduce our dynamic team. Linda?
Sorry, I was on mute. Hi, everyone. I'm Linda Detman. I'm the Associate Director for Programs and Operations for FPQC, and so glad to be with all of you this morning.
Margie.
Hi, I'm Margie Boyer. I'm an OB nurse, a nurse consultant with FPQC, and I also am doing my clinicals at HCA Trinity. So I've got to know Amanda and her team there. So real happy to be here. Thank you.
Nicole.
Good morning, everybody. My name is Nicole Pellegrino. I am a quality improvement analyst with FPQC and sort of serve as the project coordinator for the MORE initiative. Nice to meet you all.
Again, as I mentioned, this is an open discussion session. I'll walk through what we're currently doing and we're happy to be here and answer any questions you have. We call this our MORE 2.0 initiative, Maternal Opioid Recovery Effort. We've been doing this now for almost 16 months. Why focus on opioid use among women? Most people don't know, but we partnered with the Florida Department of Health and put out an urgent maternal mortality message last year. Opioid or drug-related deaths is the leading cause of death to pregnant women during pregnancy or up to a year afterwards. More women die of drug-related deaths than hypertension, hemorrhage, motor vehicle accidents, suicide, homicides. They accounted in 2018 for 1 in 4 deaths, and the rate in 2019 has gone up. And we expect with COVID, based off of other data we've seen, that it should go up again further. And the sad part is about 75% of these women die after they've been discharged from the hospital. So we as medical providers and hospitals know who the women are and had the opportunity to intervene and could have changed their course. And many of our fellow states who've worked on this have actually reduced these death rates in half. So this is a treatable chronic disease And these deaths can be prevented if we get them into a system of care. We call it more because we believe these women need more attention, more support, more services, more follow-up, and more compassion. And we've been working, we're funded by the Florida Department of Health. We're part of the ACOG National Alliance for Innovation, so we're following national bundles and processes. We steal shamelessly from other people. And we're also funded by the CDC and CDC in Atlanta. Again, we launched this initiative. We did our kickoff in November or March, or November. And we started in January. Of course, COVID hit in March. So that's why we have our extension. We're going for an extra year. If you look at our map of the states, you can see where some of our numbers are. Why does it matter? We've now learned with some of our hospitals that if their numbers in their hospitals are too small, that it's hard for them to be engaged. But if you have about 16 NAS babies a year, that's enough to keep you engaged in the process. Currently, as you may not be able to tell, but those 21 hospitals that are participating really follow our NAS belt here in the state. And many of your hospitals are also somewhat in that belt too. And that's why we've tried to reach out to you all. We really span networks with a wide variety of people from a variety of health networks. And we've actually had every health network in the state have somebody participate in an initiative with us. What are we focused on? We use the IHA model. We have primary drivers. We're really focusing on screening, both primary and secondary. We're focusing in on prevention, treatment, comprehensive discharge planning, and working on policies and procedures. There's not really a good outcome. The drug-related deaths come out really too late to use as a quality measure, though we're using it as a secondary measure to measure impact. So what we really want to do is have at least 50% of the women receive all the evidence-based recommended care that these women should have within the hospital. And so we're just trying to raise that bar in the state. And right now that bar is really low. And I'll share some of that data. Why would you want to join the FPQC, and what do we have to offer? Well, at no cost to you all to join, we provide a variety of services. One, we have project-wide, we try to do in-person. Of course, we're now in COVID, so we do it virtually, but we do provide collaborative-wide meetings where we bring in national experts and we try to help equip hospitals. We provide educational sessions and videos. We provide you rapid data reporting every month. We send you out email blasts on current updates and issues, not only with the collaborative, but with the treatment of care. We will actually provide customized consultation and grand rounds to your hospitals to help you talk through how to help work on your problems and who you can talk to and get assistance. We provide an extensive online toolbox that has algorithms and sample protocols and education for the mothers and for providers and slide sets to help with presentations. And the biggest thing that people have really started to enjoy is we do what we call coaching calls. We break you into small groups and we have you share with the hospitals and what your problems are and what's working and how you've been able to solve it. And it's really a motivating time to learn from what your peers have found out and how you can help others with their issues. We have an extensive video series to teach about substance use, including trauma-informed care, motivational interviewing, how to handle it during pregnancy, but they're about an hour long. The new thing that we've come up with was we've done some professional videos. These are 5-minute snippets. They talk about stigma, they talk about screening and expert, they talk about plans of safe care. The one that's really good is the one on first steps. This is a story of 2 women and how the care at the time of delivery changed radically their lives and the impact that hospitals can have on women with dealing with this chronic disease. The reason we like the 5-minute snippet is these are things that you can take to your nursing rounds, you can take to your grand rounds, departmental meetings. It's something that you can show to everybody to sort of highlight an issue, and they're very well done. Again, we have a variety of materials of both videotapes, but also handouts and other pieces. The other thing that we've really found that has worked, we borrowed this from Illinois and we've tested it out in 4 hospitals and they absolutely loved it. We've created what's now called the MORE folder. It has a checklist of everything that needs to happen to the mother from the time of admission to the time of discharge. It's an ideal worksheet that identifies what everybody needs to do. And if you huddle, would give you a chance to do a plan. Why do we like it? Because if you find a woman who is screened at admission to have substance abuse, you can pull this out. So no matter what day, what shift, everybody can start providing a very organized, coordinated process. And we put this into a folder. We developed a patient material booklet with Hillsborough Healthy Start in partnership that puts all together in one place, all of what the mother needs to know about her issues and what's happening to her and what's happening to the baby, what's going to happen in care, what's going to happen at discharge. It's well written. It's targeted specifically for the mothers. We've actually had mothers review it and edit it and made sure it works. We have great education material on naloxone, but we also have the expert card in there for the docs. We have a brief prep on trauma-informed care to remind people. We have the treatment algorithm. So it's a great way for the team to quickly be refreshed what they need to be thinking about doing and how they do it with these women. And the hospitals who piloted this really loved it because it really helped them work through as a team all the issues and it made it simple. We actually have now already delivered 1,100 of these across the state. So is it making a difference? Even in COVID, we are having an impact. These are the screening rates for the 14 hospitals that we have who have been able during COVID to continue to work on this and provide data. Several of our hospitals had to pause and they're now coming re-engaged. The green line is the primary screening and what proportion of women are now being universally screened verbally by an evidence-based tool. And we've gone from a little over 60% now to up to 85%. We also have a secondary screening where we screen for mental health, intimate partner violence, and infectious diseases. And all of those have now reached our goal of over 90%. Infectious diseases took a while because many hospitals were not screening for hepatitis C, which is now recommended. And so they've been getting up to speed. So our screening side has worked well. On our prevention side, our second driver, our primary focus is to help these women have a contraceptive plan and to choose the method or option that's best for them. This shows you over time whether they actually have a plan, whether they have a method or not. That's in green. Whether they decline it is in gray, and missing is in orange. And you can see that more and more of these women are actually being able to help plan, because many of these women do not want to have another pregnancy and are very interested in talking about these options. In terms of treatment, what's really important is to get these women into behavioral health and medication-assisted treatment. Right now, we're running about 35% of them getting it in pregnancy. Our Illinois and Massachusetts colleagues have gotten this up to over 2/3. We have a long way to go. And some of that is actually with initiation in the hospital. And some of our hospitals are starting to try and do that. But the idea is to help get these women into MAT. And if they're not in it prior to coming to you, to help you get them into it post-discharge. And that's where we work on comprehensive. We have a full educational bundle of what these mothers need to know and give you material to do that. But also we start working on things such as social work consultation and postpartum visits and pediatric consultation. Our behavioral MAT is now starting to go back up post-COVID, Healthy Start referrals and such. The other big piece we're pushing is Narcan. The two biggest things that we can do to impact mortality, one is get these women into behavioral health and MAT and educating them about Narcan. In fact, we're working on some programs to make that easier for you to do. We actually give material in your MORE folder that make that easy for your staff. This is a complex problem, and what we're discovering and partnering with the Department of Health and our other state partners that A lot of the system outside the hospital is not as developed as nicely as it needs to be. And so we're working in a variety of ways to make it so that you all have the resources to help support you do this. One, we've contracted with our Healthy Start coalitions to make sure that all the hospitals' resource directories for where to refer these women is up to date, and then to consult with you on the best ways you can keep up to date and know what to do, whether they're in Healthy Start or not. One of the things is we want to start plans of safe care on the neonatal side. That should absolutely happen. But all the evidence is saying that this should start, if possible, prenatally or with the mother in the hospital. And so we're working with DCF and others on developing calming messaging so that everybody can get on the same page with plans of safe care. It's basically, if you think about it, it's a discharge and a healthcare plan. It's very simple. We are actually working with DCF, and for not-for-profit hospitals, they will actually provide free naloxone for all mothers. If you can't get that into that program, we are recommending that all mothers have a prescription for naloxone while they're in the hospital. And some of our hospitals who do prescriptions actually can have it filled while the mother's in the hospital. Ideally, we want these mothers to go home with naloxone, one way or another, because that'll help with our mortality issue. And it's important that their loved ones know about it. We are really pushing on the screenings. We've done listing interviews with 3 different sets of OB providers and clearly heard all the barriers. And so we're trying to work on that. For example, we're now working with Medicaid to make sure that you as hospitals and doctors have access to a dedicated case management referral person. So as soon as you identify this women, you can call and notify the health plans, and their healthcare manager, case manager, will help get them into all the approvals and programs with you to make that more seamless. Our doctors say it takes hours to get this done, and now we're trying to make it a phone call away. We're also working on now reimbursing for ESPR so that your providers can be reimbursed for this service. We're also trying to work on education. One of the things they say is a lot of our OBs are not trained in taking care of substance abusing women. And so we're now working on potential training grants for OB residency and family practice programs, but also CME-based training for docs. And so we're now working with all of our partners. And if you have other issues that we need to work on, we have a very empowered group trying to create the change to make the system work, because we got to do this together. If you're interested in the initiative, we encourage you now to have your teams and your hospital mark your calendars. We are doing a virtual kickoff on May 20th. It's a half day. It'll be Linda remind me, it's in the afternoon, I believe. And if you want to do this initiative, the kickoff is absolutely required. We've tried to do this without having hospitals at the kickoff, and they never get going right. So again, it'll be a great kickoff and a great learning opportunity.
And it's scheduled from 1 to 4:30 on Thursday, May 20th.
Thank you, Linda. How do you apply? Well, the deadline is passed, but we take late admissions. Please do apply though as soon as you can, because not only do you apply, but each of your team members personally have to agree and commit to the initiative. We've learned to do this so that everybody understands that they're involved in trying to make this change. The application can be found on our website, fpqc.org/more. In fact, all of our materials are out there. We will need a data use agreement with you. We've done this with most of your networks already and been able to work through it and have models that we can use. We also have a data webinar. We won't do that at our kickoff because not everybody's interested in all the data mechanics. But we usually have the data leads and potentially TIM leads join us on May 27th for an hour webinar on how to submit the data. Again, if you ever have questions, if you email fpqc@usf.edu, we can get you the answers you need and to the right person. You can always call us too. We try very hard to be responsive. Again, our website is fpqc.org. Our email address is fpqc@usf.edu. We actually have Twitter at the FPQC, and really want to answer any questions that you might have at this point.
Thank you, Dr. Sappenfield. I do have a question. What data, and you might have covered this, what data is required to be submitted as part of this program?
Our data is one, we want to submit on the mothers. Most places don't have too many mothers, so we haven't had to put a cap on how many you have to enter. But again, if you only have 16 a year, it's not a lot of data.
Mm-hmm.
But we want to know specifically what's happening to the mother and the care that they're getting so that we know how you're doing and you know how you're doing and you're doing compared to others. The other thing is once a quarter, we want you to do a small sample of your general OB admissions. And you're mainly looking to see, did you screen for drug related use or not? Because the numbers are small, that we have not heard from the hospitals that our data burden is large. Usually the biggest problem has been on the other side. There's not been enough cases. But we're happy to walk through that. And if someone wants to see, I think in the application, we actually put out the data measures.
Okay.
We can provide the data tool if you'd like to see that. We could even provide you an initiative-wide report so that you can get some ideas of what actually comes out of the data that you submit. But everything that we collect is to be used. It's really related exactly to the driver, as I told you. How are you doing in your screening? How are you doing in your prevention? How are you doing in your getting people into treatment? And how are you doing with your discharge education and planning? So none of it is really extra.
Okay. What's the screening tool? What are those requirements? Because I'm assuming that's going to have to be delivered across our entire patient population.
We make recommendations, but every hospital decides what they want to do.
Okay.
With screening, there are 3 evidence-based verbal screens, and everyone wants us to choose one. And our experience is hospitals don't want to choose us to choose for them. If there are 3 evidence-based ones, we let you choose, but we'll tell you what the 3 are, and we can give you links to what they are. They're usually fairly straightforward.
Okay. For the hospitals on the line, do we currently use any of those screening tools for this in our practice now?
Hello, this is Amanda Holbrook. Yes, we do screen for history of substance abuse and current substance abuse. And for patients who have received prenatal care, we do a historical review on their lab results as well.
I encourage people to check because many do screening, but they haven't been using one of the evidence-based tools. And there is really strong evidence that you need to use one of those tools. I mean, I know some hospitals do biologic screens, but those are really not recommended. One, there are many false negatives because it all depends on which drug and which was the last time it was used. And 2, they're not reliable. That's why all the verbal screens are the evidence-based screens. The biologic screens are usually done in follow-up.
All right.
Those are good questions. Other questions?
Amanda, which hospital were you with?
I'm with the Medical Center of Trinity.
Okay.
And it's an HCA facility, so the HCA facilities do have that verbal assessment as part of their admission requirements for intake.
Nice to know.
Perfect.
Our coaching calls are once a month. Almost everyone now makes them because they're very helpful and engaging. It really helps hospitals share what's working and what's not working and problem solving. We also use that as an opportunity to talk about where you're making progress and where you're not and what you could think about trying to do. It's a great problem solving session. We also share what's going on at the state and how that is now helping you to do things. And you can also give back feedback as to what needs to change. It's been a very educational process and worked well. Margie leads one of our calls. Margie, do you want to talk a little bit about the hospitals?
Sure. Yeah, I lead one of the calls with Dr. Pam Carbiner. So I'm the nurse and she's the OB expert on the calls. And basically we just have the teams talk about their successes, any challenges, and then we offer input regarding that. Some things somebody wants a snippet on how to do the expert, or we just take feedback on what we can do to help you. But it's very collaborative. The hospitals love sharing best practices. For example, the Narcan, some of them have been able to get that Narcan easily, others have struggled. So that's what we all work together. It's a great opportunity for people to share.
Other questions, comments?
Hi, this is Suzanne Jones from Orange Park Medical Center. How does this program work with patients who are already in a program where they're currently on some form of medication to try and heal, we'll use that word, from this process?
Well, that would be the ideal situation. And generally what you're trying to do is you still may need to do your secondary screens because we find that they're not always done. We also have found that many of the women who are in treatment are using other drugs. And so it's going to be important that you find that for both the mom and the baby to figure out those pieces. While they are with you, they still may need mental health consultation. By the way, we are very closely partnered with Behavioral Health Impact Program, and that's part of the flyer, so that if you're running into mental health issues and you need a consult, your doctors or nurses can call that number within 24 hours, get a quick consult on what to do with the mother. But so there are those issues, and even then you still need to work through trying to make sure the mother stays in to MAT once she leaves, and helps her work through that. But the biggest thing you can be is an encouragement for her to stay on treatment. And your environment and what you do there is going to be critical to her transitioning, because as you can imagine, having a baby changes one's life and puts a lot of stress. And so this is your opportunity to help launch her to take care of herself while she's taking care of her baby.
Okay, thank you very much.
Again, that's the key, because again, Massachusetts and Illinois have been able to get that up to about 2/3, and we would love to do that, but we've got to get physicians to change their behaviors and do a better job of screening and referring on the prenatal side. And in Florida, we've got a long road ahead. So you as a hospital are going to end up being, I bet, still the predominant safety net for these mothers and the last opportunity to really impact them before they get discharged.
Yeah, I would suggest, if you haven't seen the Getting Real video, that you can go to our website, fpqc.org, and look at our video snippets. The one on Getting Real talks about, both those mothers talk about their hospital experience, how that was the safety net. That's what saved them. And both of them are very successful now.
And it's really the contact with the nurses that made the difference.
Yeah, I think we've seen a good bit of change here at Orange Park. Unfortunately, we have quite the high level of folks that come through here with this issue. And I would say probably half of them are in a treatment program, half are not. So I think we have definitely made some strides over the years with the whole stigma issue, and helping our nurses to understand that these patients, many of them get to this problem by, they were in an accident, they got hooked on oxycodone or whatever. They're not always just, street folk that are drug dependent. So we've tried really hard to be able to accept those things with our patients and be able to give that compassionate care, no matter what their issues are. But as you said, we have a long way to go with that. Provider issue is definitely something that I feel like would be beneficial for us to work on. Most of them, I don't know, really have all of the information that they need in order to be able to treat these patients appropriately.
And you're on our list because you have one of the highest numbers in the state. You may already know that.
Yes, sir.
And we would love to work with you all in any way that we can.
Okay. Thank you.
And I've had the opportunity to work with Amanda and Jalinda in my clinicals at Trinity, and the team there, so wonderful as far as addressing, the stigma, really working with these moms and babies. I've been very impressed with the team. They're very engaged. So thank you so much.
You.
And for
you.
those who are HCA hospitals, we actually have a long history of working with you all. We've worked with North Florida Medical Center and with Plantation. And on the neonatal side, we've done Gulf Coast Regional. So we really do work with every hospital and with every hospital system. Other questions? Again, based off the evidence that we have from other quality collaboratives, we know what we're offering you are really good change packages that can make a difference in care. They're really tested. And the question gets to be is, do you have the time and the priority to help make this work? We just know as a state, this is a major priority for us because it is our leading cause of death. I don't want to make people be on too long. Other questions? If you want to talk offline, we're happy to set up a time to talk offline. If you have problems with the application or you're not sure about something, let us know. Happy to go over data tools. Just let us know however we can assist.
This is Jill Bodden from Memorial Hospital, Jacksonville. Just a quick question of, is there a close relationship with the plan of safe care within this, or is that just looked at totally separate? I'm very involved in that here.
The plan of safe care is part of it. We are trying to push it prenatally, because if you think about it, if you get these women in the care early, that plan should start early. And it should be the same plan going through. And in fact, it's to the mother's advantage, because if she has a plan of safe care before she delivers, there's a greater chance she'll go home with the baby. Right now, over 2/3 of these babies are going home with the mom. So that's really the goal that we're trying to look for. And so if we can start those early and get them plugged in, that is good. Every community sort of has their own sort of lead group. I do know in some places Healthy Start will come in and help, but that's part of the piece that's being worked out, and we're trying to work that with Department of Children and Families. The video clip that we have in there from Halifax on a hospital perspective on plans of safe care is a very nice introduction to your hospital team.
Yes, I've actually worked with them as well. They've got an amazing program going there.
Absolutely.
So thank you. I appreciate that.
Any other questions? Well, thanks for taking the time to listen. Hopefully we persuaded you to consider us. Again, if you're interested, please do apply early. If you look in the chat, we put the application guide there. You don't have to, even if you're just not sure, all the information about the initiative is there. And so that you can go through and learn what you're agreeing to do and how. So please take advantage of that. And again, just reach out if we can answer a question. And Kristen, thank you for helping us set up today's call.
Welcome. Absolutely. Thank you for the information and for the HCA hospitals on the call. I'll circle back and just make sure you have everything you need and let me know, we'll talk about participation moving forward. So thank you so much to your team, Dr. Sappenfield.
And I know some of you are not HCA hospitals, and if you need help, just reach out to us and we'd be happy to also assist you. Well, best wishes to you guys. Enjoy the rest of the week, and we very much hope to hear from you.
All right. Thank you. Bye-bye.
Bye, guys.